Good morning, everyone. Uh, Today we'll be discussing carcinoma unknown primary of the head and neck region. So we'll start today's discussion with a case. A 55-year-old gentleman presented with a right-sided neck swelling, which was slowly progressing for a period of 2 months. He had a USD neck which was suggestive of an enlarged right-sided node, nodes in the level 2 and level 3 region. He underwent a USD guided biopsy in the same sitting from the right side level 2 node, which is suggestive of a poorly differentiated carcinoma. However, no IHC was done for further characterization. He underwent a CCT, which was not suggestive of any primary lesion. So we went ahead with a PET CT, and there was the largest node was seen in the right side level 2 node, which had already been sampled. There was also uptake in the ipsilateral level 3 and level 5 nodes. Increased uptake in the bilateral tonsils was commented as being inflammatory. So this is the imaging, and you can see clearly that on the right hand side there is a enlarged level 2 node, and there are a few reactive seeming nodes in the bilateral 1B, and there is a reactive seeming node just behind this enlarged node as well in the level 2 region. When you look at the PET uptake, you can see that below the level 2 there is uptake in the uh, so-called level 3 and maybe level 5 region as well, which so all these have been reported. So this patient was being suspected to have a carcinoma unknown primary. A biopsy was done from the right side tonsil, which came negative. So this clinched the diagnosis, and we went ahead with the right-sided MND. On histopathology, the 1B turned out to be negative, and the right side level 2 to 4 had two nodes positive, none with ENE. So the patient was staged as CT0 P into B. Uh, However, morphologically, this patient was seen to have an undifferentiated SCC, minimally keratinizing, which raised the suspicion of a nasopharyngeal origin. And indeed, on IHC, the EBV LMP1 came positive. So there was a DNA done to see the nasopharyngeal region, and there was no lesion that was found. So no further biopsy was taken. The patient was referred for adjuvant radiotherapy. So with this background, let's get into a deeper discussion of carcinoma unknown primary. So by definition, these are basically cervical lymph nodes without any evidence of a primary tumor, either on examination or on scoping. They constitute 3 to 5% of all head neck cancer region tumors, and there's an increasing incidence, especially in the West, which is largely driven by the P16 positive oropharyngeal cancers, which predominate in those regions. There's paucity of randomized controlled trials and therefore no clear consensus on what the standard line of treatment for these patients is. Treatment is mostly informed from evidence extrapolated from other head neck sites and driven by the suspected primary site as well as the nodal stage. The pathogenesis as to why we see nodes without a primary, there are two theories. Firstly, what is suspected is that maybe you have a primary tumor which is genetically malignant but phenotypically benign, which essentially means that certain genetic alterations induce a metastatic disease which migrates to the neck, but at the site of the primary tumor, it is behaving like a benign lesion, and so it does not uh, further grow in size. The other alternate hypothesis is that there may be spontaneous tumor regression, and this may be possibly due to immunological factors. So these are the two theories that are floated, but we don't know for certain. Uh, if you look at the behavior of this entity, an extensive diagnostic workup would probably lead to a detection rate of the occult primary percent of the patients. Most of these occult primaries are either from the palatine tonsil to a larger extent and base of tongue to a lesser extent. Post treatment, a small percentage reported from between 5 to 20% subsequently develop a mucosal primary, and again, most of these will be located in the oropharynx. A peculiar feature is that if you have treated an index head neck cancer uh, with, say, surgery and radiotherapy, most frequently the second primary, if there is a mucosal lesion in this particular population, most commonly appears in the oral cavity, followed by the larynx, and the oropharynx is probably at the end. This is probably because of field cancerization, especially in patients who are tobacco chewers or smokers. The prognosis of CUPs is largely favorable compared to other head neck tumors, and 5-year overall survival and local regional control rates exceed 60 to 80%. So, uh, the reason why we have to focus on HPV positivity in these patients is because typically in the HPV positive population, you will see early T stages or T1, T2 lesions with relatively large nodal disease or a heavy nodal burden. Despite this, these patients tend to do better than the non-HPV positive population, and you typically see these in younger patients, non-smokers. They don't have other comorbidities, and these end up being very chemo and radio responsive tumors. So they have a much better prognosis and they live longer, and that's why we are working at ways to de-escalate in this particular population, which also corresponds to the population that we see in the carcinoma unknown. So on presentation, any non-tender neck mass that is either noticed or growing for 2 weeks without any signs of infection raises suspicion of malignancy. Uh, Certain signs and symptoms would point towards the primary, including dysphagia or dinophagia, otalgia, hearing loss, hoarseness, nasal obstruction, and unexplained weight loss. Signs include changes in voice, either hoarseness corresponding to the larynx or hot potato voice if it is in the base of tongue. There may be some skin lesions that may be noticed. Uh, Oral cavity primaries would have trismus, uh, restriction in tongue mobility, apparent ulcers, and pharyngeal tumors would again lead to either tonsillar, soft palate asymmetry. So the nodal presentation most commonly involved nodes are the level 2 nodes, followed by 1, 2, 3, and uh, only about 5 to 10% involve the level 4 and 5 nodes. Bilateral involvement is seen in less than 10% of patients. The nodal site would hint towards the primary. If it is in the 1A region, it may point towards either the lip or the anterior oral cavity. Level 2 largely drains from almost all sides as the first echelon in the head neck, but mainly points towards either an oral cavity or more commonly an oropharyngeal primary. Uh, Level 3, you may suspect either a primary in the larynx or the hypopharynx. But if you're looking at level 4, you need to strongly suspect hypopharyngeal, thyroid, or esophageal primaries. Level 5, strong suspicion needs to go for nasopharyngeal primary. So a differential, so you need to rule out infective or inflammatory disease. Most commonly, tuberculosis is endemic in India, especially. Certain benign lesions may mimic nodal.
थोड़ा मत मत है मत डालना हल्दी मत डाल
Ma'am, if you could just mute yourself. So most common benign lesions tend to be in the salivary gland related. Other neoplasms, apart from SCCs, may include thyroid cancer, lung, breast cancer, lymphomas, and melanomas that need to be taken into consideration. So the diagnostic workup, the main objective would be to determine the histology of the metastatic tumor and to identify the primary if possible. These are the two objectives that drive our diagnostic workup. Typically, a patient comes to you in the clinic, you would start with the USG neck uh, to characterize the node, and this is obviously cost effective, minimally invasive. Uh, Once characterized, if suspicious, if seemingly suspicious, an FNAC may be the next step, and typically, if found to be malignant, 50 to 70% are seen to have squamous cell carcinoma. Subsequently, if you are at this stage, you would want to do a CECT And here you have a primary detection rate of about 40 to 50%. If the CCT is negative, then you may want to go ahead with a PET CT, which has an increased sensitivity, but it still has 15 to 20% false positivity rate. Uh, so the specificity is actually similar to a CCT. Limitations of HCT, as we discussed, false positivity because of physiological uptake or because of uptake in certain benign lesions. Uh, if you have done a recent biopsy post a scopy, then that would also light up in a PET-CT. False negatives would include either a submucosal tumor or if there are certain well differentiated tumors that would not light up. So you follow a PET CT if it is negative with an endoscopy. The reason you would want to do a PET CT before an endoscopy is uh, to get some targeted biopsies if possible. Uh, a pan endoscopy includes a direct nasal endoscopy, an upper GI scopy, as well as a fiber optic laryngoscopy or a direct laryngoscopy with or without an EUA examination. And this again has a primary detection rate of about 20 to 30%. So this is kind of just a schema of how you would go about it. So So you would start off with an examination, and if a primary is not found, you would go ahead with a USG guided FNAC. If it is suggestive of carcinoma, you do a CECT. If a primary is not found, you do a PET CT. You would have to do an endoscopy at this stage if a primary is not found, and you would want to sample any suspicious areas. Typically, time interval between the cervical mass and appearing and the diagnosis finally may take 2 to 5 months. So this is quite a long gestation. So biopsy of suspected primaries. If you have a suspicious lesion on scopy, you would want to do a targeted biopsy. However, random biopsies from non-suspicious areas are not recommended. Uh, if you have done all of this and you have nothing to show for it, you may want to repeat a USG guided. So you may have already done an FNEC. If you can do IHC markers on that, that is the first option. But if you do not have adequate sample, you may need to do a core biopsy from the node, and that would give you a better idea of the underlying histology as well as IHC to better characterize the tumor. So the IHC that is that you would not want to miss is P16 initially. If the patient comes out to be P16 positive in a non-endemic uh, population such as our own, you may want to follow this up with a HPV DNA testing either by EISH or by PCR, and this is because uh, you may have in certain situations P16 be falsely positive. If the P16 test, however, is negative, you may safely do away with further DNA testing, and you may want to do EBV testing to check whether the patient may have a nasopharyngeal primary, although this is quite rare, although not unheard. Having done all of this, if you still have nothing to show for it, there is still role of going ahead with the tonsillectomy. This is especially probably desired in single mobile uh, nodes, either involving the level 2 or level 3 region, which raises strong suspicion of the tonsil being involved, especially in non-smokers, which indicates to a P16 or HPV positive population. So if you have a unilateral lymphadenopathy, the recommendation is that you go with a ipsilateral palatine tonsillectomy. If that comes negative, you may want to do an ipsilateral lingual tonsillectomy. For bilateral lymphadenopathies, a bilateral tonsillectomy is usually not recommended uh, because of uh, base tongue lesions more commonly resulting in bilateral nodal involvement. You may want to do an ipsilateral lingual tonsillectomy followed by a contralateral lingual tonsillectomy followed by an ipsilateral palatine tonsillectomy uh, and see if you can detect the primary. The advantage of a tonsillectomy is that you achieve diagnosis and resection of the primary tumor in the same sitting. Yield for discovery of the primary is seen to be to the tune of 30 to 50% in reported series. However, there is no randomized trial comparing survival outcomes between patients who have or have not undergone ipsilateral tonsillectomy. The preferred modality for performing tonsillectomy in today's day is obviously oral robotic surgery, especially for lingual tonsillectomies. However, there has been a meta-analysis that is shown that uh, even though you have a discovery rate of about 50%, uh, there is no prospective clinical trial to show that there is any advantage of this practice. So, if you truly are dealing with a carcinoma unknown primary and you have not been able to detect a primary, the entire management will depend on the nodal stage. So, if you are dealing with a single node, the preferred treatment is a nodal dissection because these patients would not further require adjuvant radiotherapy. If the patients have multiple nodes, so in two, or if the node is large, uh, radiotherapy may be preferred considering that post neck dissection, the patient would be subjected to adjuvant radiotherapy, although there is no evidence to suggest that either is superior to one another. Radiotherapy may require concurrent chemotherapy in certain situations. So, there again, we may have an aspect where you are subjecting to a patient to uh, bimodality management. In patients with very large nodal burden, so maybe greater than 3 nodes, or with clinical radiological ENE, there because the patient would require trimodality if you operate these patients, which is significantly more morbid. Typically, you would reserve definitive chemoradiotherapy upfront for these patients. The objective of management in COP should be to reduce morbidity, considering no upfront treatment has been shown superior to the other, and uh, we know that as an entity, these patients typically do better than the other head neck carcinoma. So the NCCN as well, in their recommendation, suggests that in N1, you prioritize a neck dissection, but you also have the option of radiotherapy. And in N2 to N3 disease, you can either do a neck dissection or radiotherapy with or without chemotherapy. And you can reserve induction chemotherapy for either unresectable, borderline resectable, or for volume reduction if you're treating with radiotherapy. So, surgery versus radiotherapy, as we discussed, there have been older retrospective studies that have shown that upfront neck dissection may be beneficial, although more recent studies which have incorporated more modern techniques of radiotherapy, including IMRT, shows that regional control rates may exceed 90%. And recent comparative studies have not shown any statistically significant difference in regional control or OS between primary surgery or radiotherapy. So, if you do choose to go ahead with surgery, the extent of your surgery would depend on the predominant primary site, which is the oropharynx. So typically, you go ahead with the level 2, 3, and 4 neck dissection. Additional nodal basins may be dissected based on the location of the tumor, the nodal burden, and presence of ENE. Despite the possibility of, so you may be dealing with oropharyngeal tumors which may drain into bilateral neck. Uh, you may want to do a unilateral neck dissection to avoid the morbidity of doing a bilateral dissection. So in adjuvant treatment, if you have an N1 tumor without, if you have an N1 disease without any extra nodal extension, you may choose to observe these patients. Uh, if the single node is more than 3 centimeters, so essentially N2A or multiple nodes, you would want to give adjuvant radiotherapy in these patients. And as we discussed, extranodal extension would require adjuvant CTF. If you do choose to treat the patients with radiotherapy, IMRT is the preferred modality. This reduces morbidity to a great extent. Dose fractionation depends on whether you want to treat the patient upfront definitively or with adjuvant radiotherapy. Definitive volumes typically will be either high risk or low risk. High risk is for the gross nodal disease. This is typically 70 grain 35 fractions. And low risk areas are the areas suspected of microscopic subclinical spread, and these receive 56 grain 35 fractions. If you're giving adjuvant radiotherapy, typically high risk regions are not present because you would have dissected everything. But if you have an R plus resection, again, here you would want to give about 66 gray and 30 fractions. In the intermediate risk region, which we typically do not treat in the definitive setting, uh, at least in our practice, we don't treat patients sites that are involved by the nodal disease pre-op would receive 60 gray and 54 gray and 30 fractions would be delivered to the subclinical site. Volumes are typically unilateral, especially if it is a unilateral single level 2 node without E&E. But there is a rationale for giving bilateral neck irradiation, especially if greater than two nodes are involved. If the nodal size is more than 6 centimeters, so essentially N3 disease, or if there is ENE, which is again N3 disease. Uh, Coming to mucosal radiotherapy, so far we have discussed radiotherapy to the neck. Uh, Previously, when we gave conventional radiotherapy, typically the entire mucosa between bilateral portals would be treated. And so, radiotherapy essentially would involve uh, incidental treatment of the oropharynx, larynx, hypopharynx, depending on the levels of nodes that we are treating. In the IMRT era, there was some investigation into the role of mucosal irradiation, where you would treat the entire aerodigestive tract from the nasopharynx right down to the hypopharynx and larynx. These doses were typically lesser, between 50 to 60 gray, and constituted the low risk volume. However, recent studies have shown that uh, we probably are not uh, benefiting the patient by treating such large volumes. And recent recommendations have suggested that mucosal irradiation be reserved for either HPV positive patients, where you would treat the ipsilateral oropharynx, or EBV related, in which case you would treat the patient like a nasopharyngeal carcinoma. So these are just some studies that have reported on total mucosal irradiation. On the left, you can see in this table, typical doses have been around 54 gray. Uh, uh, the chemotherapy can be variable depending on practice. Mucosal emergence was very low, uh, less than 10% in most cases, and OS was above 60% in most cases at 2 years. However, toxicity, if you see the late grade 3 toxicity, this was quite high to the tune of 30 to 40%, and we don't have any evidence to suggest that mucosal and total mucosal radiotherapy benefits patients. So it's largely not been practiced in recent years. On the right, you can see a comparison between ipsilateral and bilateral radiotherapy. So here again, the outcomes don't significantly differ to each other. So This is a rationale for avoiding ipsilateral radiotherapy as much as possible. But in patients with high nodal burden, as we discussed, bilateral radiotherapy may be necessitated. So these are the GEOC recommendations, which is just a compilation to kind of showcase what we already discussed. Uh, Primarily, you should try and treat the patient with ipsilateral neck irradiation. Uh, Pharyngeal mucosa should be treated only if the patient is HPV or P16 positive. Bilateral should be irradiation should be considered in patients with greater than 2 nodes or with N3 disease, and the nasopharynx should be treated in the EBV positive population. So returning to our case, so if we could do something differently in this patient, the first clue that we kind of got was when the patient was seen to have a poorly differentiated carcinoma, uh, and we could have gone ahead with IHC to confirm the histology further. So, although we have done a thorough diagnostic workup for this patient, we have not chased the histology as much. Another clue was that the patient was reported as having level 5 nodes. So, considering that this patient is now EBV positive, and recommendations suggest that you treat this patient as a nasopharyngeal carcinoma, the plan has now changed from giving adjuvant radiotherapy to treating the patient with concomitant chemotherapy and radiotherapy, where we have included the nasopharynx in our target volume. So this is to illustrate the target volume. Essentially, what you see in pink is the high risk clinical target volume on the left, which corresponds to the level 2, level 3, and level 5 regions. We have included in dark green the low risk volume, which includes the nasopharyngeal mucosa and the contralateral level 2, level 3, level 4, and level 5. These are all volumes as per nasopharyngeal primaries. If this patient did not have a nasopharyngeal primary, we would not suspect of having a nasopharyngeal primary. We would have not treated the patient with bilateral irradiation, considering the patient had only 2 nodes without gain. So this is what the volumes look like. And this is the dose distribution that we have achieved. So in the yellow is the highest region corresponding to level 2, level 3, and level 5. Bilateral, the nasopharyngeal mucosa bilaterally has been treated to a low dose. The contralateral level 2, 3, 4, and 5 regions have been treated to a low dose. Thank you.